Hello, my name is Susan Baker. I am a nurse practitioner practicing in a hospitalist group in Nash County, North Carolina. I am asking for you to join the campaign for the APRN consensus model. Before I go into what the consensus model is, I would like to give you a little background on why I am so passionate about this campaign. I live in Roanoke Rapids, North Carolina, which was recently named the third poorest city in the U.S. according to Census Bureau data. Halifax County and surrounding counties are all designated as medically underserved. In fact, over half of the counties in North Carolina are medically indigent or low income. In the United States, 60 million people, or approximately one-fifth of the U.S. population, reside in more than 3,000 physician shortage areas. So I want to tell you next what APRNs are. APRNs are certified registered nurse anesthetists, certified nurse midwives, clinical nurse specialists, and certified nurse practitioners. The populations they serve include family practice, adult gerontology, pediatrics, neonatal, women's health, and psych mental health. Qualifications of APRNs include graduation from accredited graduate and postgraduate programs, be nationally certified in order to practice, have knowledge in health promotion and disease prevention, diagnosis, treatment, and evaluation of acute and chronic illness, and prescribe pharmacologic therapy. Currently, there are greater than 267,000 APRNs in the U.S. They practice in hospitals, private practice, home health, schools, and other clinics. The demand for APRNs is on the rise. There are decreasing numbers of primary care physicians coming out of residencies. Looking at the graduation rates for 2014, there were approximately 19 new primary care physicians per 2,000 nurse practitioners. All of these nurse practitioners could fill a huge gap in primary care. However, barriers will restrict the capacity to which they can practice. There are also millions of newly insured due to implementation of the Affordable Care Act who will need medical care. In North Carolina, the majority of counties are in rural areas, and most physicians choose to practice in urban areas. So next I want to tell you what the APRN consensus model is and how it will help North Carolina. The APRN consensus model was developed by the National Council of State Boards of Nursing. It calls for uniform regulations and standards on a national level for APRNs. Its major elements include state recognition as an APRN, title of an APRN, licensure as an APRN in one of the four roles, those being certified nurse practitioner, certified registered nurse anesthetist, certified nurse midwife, or clinical nurse specialist. They must meet minimum education requirements of graduate or postgraduate education and must have independent practice and prescribing. This is where North Carolina falls short in the consensus model. So advanced practice nurses are regulated by individual states. Approximately 1/3 of all the states already allow APRNs to practice to their full scope without physician oversight. All other states have varying rules regarding APRN physician relationships. Many are inefficient and restrict critical access to care. So in North Carolina, the Board of Nursing and Board of Medicine have dual governance of NP practice. Nurse practitioners are authorized to be a Medicaid provider and can diagnose, treat, make referrals, and prescribe controlled and uncontrolled pharmacologic agents with physician collaboration. Collaborative practice agreements dictate nurse practitioners' scope of practice. This requirement limits the ability of NPs to practice in rural settings which require independence. And this also includes CRNAs, who often are the sole providers in many rural hospitals for anesthesia care. So the ultimate problem with this requirement of physician collaboration is it limits the access to patient care at a time when demand is continuously increasing. The baby boomers aren't going anywhere. So let me tell you what the research says about APRN practice. Unrestricted practice of APRNs can improve outcomes and reduce healthcare costs. Their care is comparable to that of physicians in all areas, including health status, use of specialists, and satisfaction. The ratio of malpractice and adverse actions for nurse practitioners was 1 in 173 compared to 1 in 4 for physicians. There is no difference in neonatal outcomes between certified nurse midwives and OBGYNs, and fewer interventions were used by midwives, which equal cost savings. There is no statistically significant difference in mortality rates in patients treated by CRNAs independently and those who consulted with the anesthesiologist. There was also no difference in mortality rates in patients treated in hospitals where CRNAs were the sole provider of care versus hospitals where anesthesiologists were present. The removal of supervision for CRNAs does not increase surgical risk or complications. In fact, mortality rates were lower for CRNAs than anesthesiologists in opt-out states, meaning states that do not require a collaborative practice agreement. Nurse practitioners are also more likely than medical students to remain in primary care versus specialty areas. And patients receiving maternal, prenatal, and infant health education by clinical nurse specialists experience less hospitalizations and readmissions, equating to cost savings of greater than 750 hospital days and $2.8 billion per year. So there is a lot of financial incentive to advanced practice registered nurses having independent practice. We're not asking to take the place of physicians, only to have the independence to practice to our full scope to provide better access to care where it is needed most. As you can see, in North Carolina, the medically underserved areas are most counties in the state. Independent practice and prescribing for APRNs is the final element North Carolina needs to join the APRN consensus model. I ask your support in joining the APRN consensus model and supporting legislation to promote increased access to care. Thank you.